A very good afternoon to one and all. I'm Dr. Sidra Ansari, and in this session, I'm going to talk about orofacial and neck infection. Now, basically, orofacial and neck infection are most dreaded complication seen by a maxillofacial surgeon. Now, this is mainly because the patient do not come to us at an early time. Only come to us when there is severe facial asymmetry or a swelling or the patient is in severe pain. Rest of the time, patient try to do some other treatment modality to just decrease the pain rather than removing the cause. Now with this, let's move on to the etiological factors of oral facial infection. Now based upon the origin of infection, you can classify the etiological factors as odontogenic factor, trauma, implant surgery, reconstructive surgery, then contaminated needle punctures or oral malignancies. Based upon the causative organism, etiology could be bacterial infection, viral infection, fungal infection. Now let's move on to the pathogenesis of odontogenic infection. Now because of dental caries and cross destruction of the tooth, the bacteria invade the enamel dentine and ultimately enter into the pulp. As soon as the bacteria enter the pulp, it causes inflammation, edema, which causes lack of collateral blood supply, which eventually result in venous congestion and avascular necrosis or pulpal death. Now this avascular necrosis and pulpal death act as a reservoir for the bacterial growth, thus providing an anaerobic environment for the bacteria to grow. Now once the bacteria start growing, the periapical ingression of the bacteria into the surrounding alveolar bone take place. That is, the infection spread to the periapical area, resulting in periapical inflammation, infection, granuloma and eventual abscess formation, which moves through the part of least resistance, that is the bone, the soft tissue, the periosteum, the soft tissue, the alveolar connective tissue, that is the path of the least resistance. Now, anatomical factors that influence the direction of spread. Now, these are the site of the source of infection, whether the upper tooth is involved or the lower tooth is involved, the point at which the pus escape from the bone and discharge into the soft tissue. For example, if a lower molar is involved, if the pus or the infection is spreading from the bone but it is coming out into the oral cavity above the mylohyoid muscle, then this will result in sublingual swelling or sublingual abscess. But if it moves down below the mylohyoid muscle, it will result in submandibular swelling, that is submandibular infection. Now, the natural barrier also, that is the layer of the fascia, muscle and the jawbone also play an important role in the direction of the spread of these infection. Now, this is a diagrammatic representation of a tooth and the spread of infection that can take place. From the upper molars, or you can say upper tooth, the infection can spread through the palatal region, that is between the palatal bone and the palatal mucosa, resulting in palatal swelling or palatal abscess. Then, or the infection from the buccal root can enter either into the buccal vestibule, resulting in vestibular space infection, or it could be between the buccinator muscle and the skin, resulting in the buccal space infection. If it is there, anterior tooth are involved, canine is involved, can result in canine space infection. In case of the lower molars, as I mentioned earlier, if the infection moves above the mylohyoid muscle, result in the sublingual gland, and below the mylohyoid muscle, it causes infection of the submandibular space infection. Similarly, it could cause infection can spread into the buccal vestibule or in the buccal space. Now, infection progress can vary. Now, this depends upon the number and virulency of the organism, the host resistant, the anatomy of the involved area, the local factors, that is the intact anatomical barriers. Now, let's move on to the stages of infection. Now, stages of infection consist of 4 parts, that is inoculation. It starts from the first day till the 3rd day, that is seeding of the bacteria take place. Resulting in mild pain, there will be soft, small, doughy, mildly tender swelling will be present. Now this, if not treated, can result into cellulitis by 3rd to 7th day, wherein there is severe generalized pain, there is large, diffuse, hard, severe tenderness swelling is there. Now cellulitis, if not treated, will progress into abscess, okay, after more than 5 days. Now abscess, there will be localization of infection, so there will be localization of pain. You will have a small, discrete, fluctuant, tender swelling. If the virulency, that is the host resistance, is better than the virus, then automatically resolution occur. If You will drain the abscess and eventually resolution will occur. Now, let's move on to the potential facial spaces. Now, what exactly are these facial spaces? They are nothing but layers of the fascia, spaces between the layers of the fascia. Now, these spaces are basically filled with loose connective tissue and various anatomical structures like vein, arteries, gland, and lymph node. They basically provide the space for these structures. Okay. Now, in head and neck region, the fascia are divided into two main groups, the superficial fascia and the deep cervical fascia. The deep cervical fascia is further divided into superficial layer, that is the anterior layer, the pretracheal fascia, that is the middle layer, and the prevertebral fascia, that is the posterior deep layer. Now, potential spaces of the jaw, based upon their mode of involvement, we could broadly divide them into direct involvement, that is primary spaces, indirect involvement, that is secondary spaces. Primary spaces are further divided into those occurring in the maxilla and mandible. For example, maxillary primary spaces are canine space, buccal space, vestibular space, palatal space. Whereas mandibular spaces are sublingual, submandibular, submental, vestibular space, buccal space. These are primary spaces of the mandible. Now, secondary spaces are pterygomandibular space, lateral pharyngeal space, retropharyngeal space, superficial and deep, that is temporal spaces. Now, these are basically, they arise from the primary space. Directly infection doesn't occur. They basically arise from these primary infection because of the spread of infection in the path of least resistance. Now, vestibular space infection. We will see each of these space one by one. We begin with the vestibular space infection. It is a potential space between the oral mucosa and the muscle of facial expression, that is the buccinator muscle. This mostly occur in the posterior region. It could either be the upper quadrant or the lower quadrant. Now, this is mainly because of the infection of the posterior tooth, wherein their buccal root drain into the, you can say, buccal vestibule. Now, they will appear as a localized swelling in the vestibule. This is the area will be inflamed, soft and tender. If it is large, it could cause extraoral swelling. If it is small, extraoral swelling is not there, just intraoral swelling is there. Now, how do you treat it? You have to remove the offending cause, that is the carious tooth. If you can restore it, do a root canal treatment, and you can drain the space through the canals. Or if you cannot restore it, do an extraction. Sometimes even after extraction also not able to drain it. So you have to give an incision and drainage and then drain the vestibule. Now, when will you give incision and drainage? When the swelling will have a point of break. That is, you will see an area wherein it is just about to break from that area. In that area, you will use an 11 number of blade, give a nick and drain it and give an antibiotic pause. Now, palatal space infection. Now, it's an area between the palatal mucosa and the palatal bone. It basically arises from the palatal root of the maxillary lateral incisor, from the premolars and molars of the maxilla. Now, it is a well-localized swelling will be there. Now, since the palatal mucosa is strictly adhered to the bone, the swelling can cause severe pain because of the greater palatine innervation is there, which is getting compressed because of the swelling. So, there will be severe localized pain in that area. The swelling could be soft to doughy in consistency. Now, treatment is similar. You need to extract the tooth if it is non-restorable, or you need to do a root canal treatment. Very rarely you have to do an incision and drainage in this area. Most of the time doing a root canal treatment and an extraction, it will automatically drain the space. Now, we come to canine space infection. It is a region between the anterior maxilla and the levator muscle. Now, the infection from the root of the maxillary canine can cause canine space infection, or canine space infection can also arise when there is a already present buccal space infection or vestibular space infection. Now, it is characterized by swelling lateral to the nose, which obliterate the nasolabial fold, and since the infection can spread between the two heads of the levator muscle, it is spread through the corner of the eye, that is the medial canthus, and resulting in the swelling of the lower eyelid and the medial canthus of the eye. Now, buccal space infection. We begin with the boundaries of the buccal space. Anteriorly, it is bounded by the modulus, posteriorly by the pterygomandibular raphe, superiorly by the zygomatic bone, inferiorly by the mandible, laterally by the skin, and medially by the buccinator muscle. So it is basically space between the skin, subcutaneous tissue and the buccinator muscle. Now it can communicate to canine space, submasseteric space, infratemporal, superficial temporal, lateral pharyngeal, pterygomandibular and submandibular spaces also. Now basically infection from the upper premolars, molars and lower molars can result in buccal space infection. Now the swelling will develop between the subcutaneous tissue, as I mentioned earlier, is between the muscle, the buccinator and the skin and subcutaneous tissue. Now how will you drain the swelling? Okay, either you could opt for an extraoral approach or an intraoral approach. Okay, depending upon, as I mentioned earlier, you will see a point of break either in the skin or oral mucosa wherein the area will become whitish, that is, the pus will start to come out of it. So depending upon that, you will drain it either intraorally or extraorally through the vestibule. Now this slide shows a picture of a patient wherein there is involvement of the canine space, the buccal space and the submandibular space. This is how the infection look like. The eye is closed because of the swelling in the infraorbital area and the swelling of the medial canthus involving the buccal area and the submandible. Now we move on to the submandibular space infection. Now submandibular space is bounded anteriorly by the anterior belly of digastric, posteriorly by the posterior belly of digastric, superiorly by the mandible inferior to the attachment of the mylohyoid, laterally by the skin, superficial fascia, platysma, medially by the mylohyoid, hyoglossus and styloglossus muscle. Now submandibular space infection communicates to the buccal space, submental space, sublingual space and lateral pharyngeal space, and its etiology is more commonly the lower molars. There will be a swelling in the submandibular gland. Now this slide shows a diagrammatic, or you can say a pictorial representation how you will drain to an incision and drainage of submandibular swelling. Okay, here you will prep the area first with betadine, thoroughly scrub the area. Then you will take a 15 number of blade and give a nick on the most dependent part wherein the pus, you will see the skin will change in that area. Punctum will be formed, or you can break through the skin at that area. You will give an incision over there. Okay, once you do an incision, you will take a hemostat, or you can say a Hilton's forceps is inserted, and you insert it inside, try to open it. You're trying to break the locules that are formed inside. Okay, now Hilton's forceps or a curved hemostat, try to insert it again and then open it. Then change your direction, insert it again and then open it. Okay, you can see the pus that pools out, and then you put a drain and secure the drain with a stitch to the skin. Now, let's move on to the submandibular space infection. It is bounded superiorly by the mucosa of the floor of the mouth, inferiorly by the mylohyoid muscle, laterally and anteriorly by the medial side of the mandible, posteriorly by the posterior border of the mylohyoid, and medially by the muscles of the tongue and genioglossus. Now, it communicates with the lateral pharyngeal space, submandibular space and sublingual space on the other side. Now these arises basically from the infection of the lower molars, premolars and surgical trauma. Characteristic feature is that the tongue is displaced superiorly, resulting in airway obstruction. So you need to decompress the swelling because you don't want to compromise the airway. Now how do we drain it? Either intraorally by giving an incision parallel to the submandibular duct, or extraorally through a submandibular approach. Now extraoral approach is used where there is submandibular swelling also, because you will approach the sublingual swelling through the submandibular swelling, then the mylohyoid muscle, then the sublingual swelling. Okay, let's move on to the pterygomandibular space infection. Now pterygomandibular space is bounded laterally by the medial surface of the mandible, medially by the medial pterygoid muscle, anteriorly by the pterygomandibular raphe, posteriorly by the parotid capsule, okay, superiorly by the lateral pterygoid and inferiorly by the pterygomasseteric sling. Now it communicates with the lateral pharyngeal space, retropharyngeal space, infratemporal space and submandibular space. Now these are basically caused because of needle tract infection, can be because of mandibular third molar, and pericoronitis can also result in pterygomandibular space infection. The classical clinical feature is there will be swelling of the soft palate, tonsillar pillars and deviation of uvula to the midline. Then you move on to the temporal space infection. Now temporal space are of three types. superficial temporal space, deep temporal space, and infratemporal space. Okay. Superficial temporal space is basically a space between the temporalis muscle and the skin. Okay. And it communicate with the buccal space infection through the buccal pad of fat and masseteric space infection through the loose areolar tissue. Thus, superficial temporal space is bounded medially by the temporalis muscle, laterally by the skin, posteriorly by the attachment of the temporal fascia, that is fascia to the pericranium, superiorly attachment of the temporal fascia to the superior crest of the temporal bone, inferiorly by the zygomatic arch. Now basically superficial temporal, that is space infection, can be drained either extraorally or intraorally. Now superficial temporal space infection communicates with the deep temporal space infection. They occur simultaneously, and the clinical picture is there will be severe pain and trismus along with the swelling. Okay. Now we move on to the boundaries of the deep temporal space. Now deep temporal space is bounded laterally by the temporalis muscle, medially by the squamous temporal part of the bone, inferiorly by the lateral pterygoid muscle, and superiorly by the muscle attachment to the cranium. Now anteriorly it is bounded by the lateral rim of the orbit and posteriorly by the pterygomaxillary fissure. Now, as I said, it communicates with the superficial space infection. So similarly, you could drain this space also either intraorally through the vestibule or extraorally from the suprazygomatic incision. Let's move on to the infratemporal space infection. Now basically what is an infratemporal space boundary? Okay, so it is bounded medially by the lateral pterygoid plate, laterally by the temporalis muscle tendon and the coronoid, superiorly by the greater wing of sphenoid, inferiorly by the, you can say, lateral pterygoid muscle, and anteriorly by the and posterior superiorly by the condyle attachment of the muscles. Now infratemporal space infection can arise because of the pterygomandibular space infection, buccal space infection. Now these are not primary space infection. They basically arise as a secondary infection because of some other primary space are involved. Alright. How will you drain the space? You drain it from the intraoral area, from the maxillary, that is vestibule. Now similarly, I forgot to mention that infratemporal space infection, classical feature will be pain, trismus and spike of fever is seen in that case. Now, lateral pharyngeal space infection. Lateral pharyngeal space is also called as parapharyngeal space. It is bounded superiorly by the skull base, inferiorly by the hyoid, anteriorly by the pterygomandibular raphe, posteriorly by the prevertebral fascia, medially by the buccopharyngeal fascia, laterally by the superior layer of the deep fascia. Now it communicates with the parotid, masseter, peritonsillar, submandibular and retropharyngeal spaces. Now it causes marked airway obstruction. It is a dreadful condition since the airway is compromised. The person doesn't die because of the infection but die because of asphyxia. So you need to have an absolute airway control. You need to aspirate it. Or anterior compartment drainage, you can do it intraorally, and in case of posterior compartment you could do an extraoral or submandibular approach, that is drainage. Let's move on to the other space, that is the retropharyngeal space infection. It runs along the entire length of the neck. It is bounded anteriorly by the pharynx and esophagus, that is buccopharyngeal fascia, posteriorly by the alar layer of the deep cervical fascia, superiorly by the skull base and inferiorly by the superior mediastinum. Now the classical feature of retropharyngeal space is dyspnea. There will be dysphagia, bulging of the posterior pharyngeal wall and neck stiffness. This is also a very life-threatening condition associated with septicemia, tagxemia, pyrexia, everything. Now treatment is intraorally, you can drain it, or extraorally. Extraorally, you can drain it through carotid triangle approach, through lateral aspect of the thyroid cartilage, medial to the carotid sheath. Intraorally, you can give vertical incision in the mucosa of the pharyngeal wall, do a blunt dissection to the superior constrictor and then enter into the space. Now, the danger space. It runs along the entire length of the neck anteriorly bounded by the alar layer of deep cervical fascia, posteriorly by the prevertebral layer, extend from the skull base to the diaphragm, contain basically loose areolar connective tissue. Once the space is involved, the infection spread haywire because it contains just loose areolar connective tissue which doesn't provide any resistance to infection. As the name suggests, danger space, its clinical feature is also very deadly. That is, it causes dyspnea, chest pain, hot potato voice. Since it causes so much of constriction of the larynx, the patient is not able to talk. There is perineural infection, mediastinal abscess formation, emphysema, and pericarditis. Then we come to the most dreaded condition seen by maxillofacial surgeon is Ludwig's angina. It is nothing but simultaneous involvement of both the submandibular, sublingual, and submandibular spaces bilaterally. Characterized by browny hard swelling, it is basically a cellulitis. The floor of the mouth is elevated, resulting in airway obstruction, difficulty with respiration. There is edema of the glottis. First of all, since there is edema of the glottis, there is laryngeal edema also. Along with that, the floor is also raised. So completely airway obstruction can occur. So person dying along with septicemia die because of asphyxia. Now, fate of Ludwig's angina is, if untreated, can be fatal within 12 to 48 hours. So the primary treatment is early diagnosis, maintain a patent airway, intense and prolonged antibiotic therapy, extraction of the offending disease, and surgical drainage and decompression is a must. Now, how will you maintain the airway? Now, intubation you have to do with the patient, but intubation is a blind intubation. You're not able to see it. So do not do a multiple attempt. Otherwise, you could cause trauma or insult. And if you go on injuring, there will be increased inflammation, which will worsen the edema and airway will be obstructed. At the same time, you might puncture a superficial abscess in the laryngeal wall. Okay, and then this could spread aspiration of the pus and cause instant death. So just a single attempt of intubation. If you are able to do it, well and good. If you're not able to do it, opt for a surgical airway. Now, surgical airway is in form of a cricothyrotomy or a tracheostomy or a thyroidectomy you can do. Now, surgical decompression. You have to give bilateral submandibular incision, midline submental incision, 1 centimeter below the inferior border of the mandible to drain the involved area. So before you go for an incision, you will take the patient in general anesthesia, anesthetize the patient, prep the area, thorough aseptic protocol. After you prep the area, give the nick, do superficial dissection, deep dissection, platysma, enter into the submandibular gland from both the sides, submandibular space. Then through the submandibular space, drain the submental and sublingual space. Put a corrugated drain. At the same time, keep in mind that try to avoid injury to the facial vessels which are near to the angle, lingual nerve and the jugular vein which is laterally below the angle region. Remove the offending cause also at the same time. But when you're placing a drain, you have to keep in mind that it is a cellulitis. It might not drain when on the first day of your surgical attempt. It might drain after 2-3 days. So whatever you dissect it, drain it, put a drain and secure it, and then eventual discharge will occur. An antibiotic therapy is a must. When you do this incision and drainage, you will get some specimen which you can send for antibiotic and culture therapy, and then based on that you can also start with your specific antibiotic. Meanwhile, initially you will start with empirical antibiotic. Now these include penicillin, which are the first lines of antibiotic, which are in form of penicillin G, 2 to 4 million units IV, 4 hourly, or if the patient can be ambulatory, then oral 500 mg 6 hourly. You could also give amoxicillin 500 mg 6 to 8 hourly IV or cloaxacillin 500 mg orally or 8 hourly. If the patient is allergic to penicillin, you can opt for erythromycin 600 mg 6 to 8 hourly. Hydrate the patient. Check the blood pressure, pulse and urine output. The patient is severely hydrated. Take an IV line. Start with IV fluids. Monitor the temperature. Also apply cot packs to decrease the pyrexia because the patient is in septic shock. There will be spike in temperature, so you have to monitor the temperature. Take the chest x-ray to rule out if there is any kind of pneumonia because of aspiration of the pus. Then evaluate laboratory data continuously. Do blood culture and protein analysis. Now, post-operative care of these patients. Extubation after confirming adequate airway. Since I mentioned earlier, when you're doing an incision and drainage in Ludwig's angina, the procedure is under general anesthesia. So when you're trying to extubate the patient, see that the patient is able to maintain his or her airway. Then only you extubate. Otherwise, keep it. Now, irrigation of the drainage periodically. Culture report you have to do to determine the culture sensitivity organism. Re-evaluate the laboratory test, do blood count, monitor the cause of infection. If necessary, you can re-explore and drain again. Have a thorough follow-up. Last but not the least, cavernous sinus thrombosis. Now this occurs because of extension of a septic thromboid into the cavernous sinus through the venous system. Now it's classical sinus pain in the eye, diplopia, proptosis and ptosis. Picket fence fever, which is nothing but fever with chills and rapid fluctuation in blood pressure. And then if it is not treated, it can result in toxemia and meningitis. Treatment is start antibiotic therapy and heparinization. Heparinization will help to eliminate the clot which is there in cavernous sinus and prevent the condition. With this, I would like to conclude by saying that incidence and severity have diminished with the advent of antibiotic therapy of these orofacial infection. But that doesn't mean that we keep our alert at a side. We have to be alert for the potential seriousness of these infections. Never to dismiss any simple dental abscess because these dental abscesses can result in potential space infection. Now, deep facial infection must be recognized early and treated as an emergency because they compromise the patient airway and put the patient at high risk. At the same time, do a repeat diagnostic and therapeutic measures anytime that is necessary till the end point, till you see that the cultures and all are normal, and then you stop with your diagnostic modalities. Thank you.